about refining treatments, and it's a real pleasure to introduce Dr. Jay Biswas. Jodie's going to talk to us about milestones in uveitis therapy and where we are now. Thanks, Dr. JB.
Good afternoon. I'll be talking on milestone in uveitis management. Uveitis management, we have come a long way and we are going forward to it. And I would be sketching out the milestones in uveitis management. It was 1950 when is the real development came when Gordon used a steroid for ocular inflammatory disease. And since then, we are still using steroids for various types of non-infectious and even infectious ocular inflammatory disease. 16 years after, Dr. Ong from Washington used mercaptopurine and methotrexate for managing ocular inflammation. It took 28 years after when CMT42 and etanercept was used, which are the biologic agents from inflammatory eye diseases. Treatment strategy today is the corticosteroid still remains the mainstay of treatment, which cannot be overemphasized. Then the immunomodulators, and finally today we are now having biologics, a new armamentarium in the management of uveitis. So I want to remind you again that the corticosteroids and immunosuppressive agents still remains the mainstay in every part of the world. So topical steroids, I don't want to again repeat it, it is very good for treating the mainstay of treatment of the anterior uveitis, acute anterior uveitis, and we use the topical steroids, mydriatic and cycloplegic agents. Non-responding, we add systemic steroid. Non-responding, we can add immunosuppressive agents. So this is the algorithm for management of anterior uveitis. Intermediate uveitis, we use the modified Kaplan protocol. Posterior subtenon injection is the first step, then step-ladder approach, oral prednisolone, immunosuppressive agents, and finally vitrectomy. Posterior subtenon injection, triamcinolone acetonide, as you know, is given in the posterior subtenon space. And oral steroid in intermediate uveitis, severe bilateral cases, failed periocular injections, 1 milligram per kilogram of the taper 10 milligram per week, low dose of steroid if protracted course. Management of the posterior and pan uveitis is the systemic steroid remains mainstay of the therapy of non-infectious posterior and pan uveitis. Why? Is the peak effect is very quick, within 1 to 2 hours. Dose is 1 milligram per kilogram of the day, taper by 10 milligram per week. And counseling the patient about the side effects is very important. We follow the Douglas-Japs schedule, most of us, and so it's the right choice because it's a greater general experience with the drug and low cost, relative safety, and quick action. When still we need a quicker action, we choose intravenous methylprednisolone. And now it has come the milestone in uveitis is the intraocular steroid implants and intravitreal injections. So dexamethasone intravitreal implant was studied by Karen Loader et group in the Archives of Ophthalmology is published. There's a Huron trial, and we found the dexamethasone implant, 700 microgram, is very useful. 700 microgram. This is a glaucoma 7%, cataract 15%, though it can occur, and which is can be treated with the medical treatment and surgery. So implant is placed, is a biodegradable implant, is placed in the vitreous cavity of the eye with a single-use applicator, sutureless office-based procedure. We use this implant in the treatment of non-infectious intermediate uveitis and found to be quite efficacious and with a good safety range. Intravitreal fluocinolone acetonide ILUVIEN came in 2022 when the intravitreal 0.9 milligram fluocinolone acetonide implant is given, safe in selected glaucoma patient even. And then there is a This is a Iluvien, and then we have got another intravitreal implant, 0.1 milligram, 8 milligram fluorouracil implant, which is called UTIC, and which is quite often used in the Europe. 2023, we published an article of 0.2 microgram per day fluorouracil intravitreal implant in chronic non-infectious uveitis, which have done a 3-year randomized trial in 15 centers of India and found reduced uveitis recurrence, increased time to first recurrence, control over macular edema, maintains stable IOP levels and expected safety profile, and high rate of cataract formation. Immunosuppressive agents, I don't want to go into details, all of us are aware of it. The prerequisite, of course, is the absence of infection and reversibility of the disease process. And the top on the list is Behçet's disease, sympathetic ophthalmia, VKH, GI-associated disease, serpiginous choroiditis after ruling out TB, and chronic intermediate uveitis. I don't want to go into the details of the immunosuppressive agents, all you are aware of it. And immunosuppressive agents in anterior uveitis is usually not required except for JIA and intermediate uveitis in refractory cases only, and in case of posterior and panuveitis, Behçet's disease, VKH, sympathetic ophthalmia, serpiginous choroiditis after ruling out TB. On the backdrop of this basic treatment modality, we have got now biologics, which is a milestone in uveitis, and it is a biologic response modifier born of recombinant DNA technology, blocking the activity of the bioactive mediator of the immune response. And these are the biologic agents, TNF-alpha inhibitors, that is that anti-interleukin, CD20 B cell-directed molecule, and interferons. TNF inhibitors, of which we are more familiar with adalimumab and infliximab and golimumab, and anti-interleukins, tocilizumab, which are quite familiar with the usage in the COVID era, and in case of CD20 antibody against B cells is the rituximab. So these are the why use biologics? It's an alternative in inadequate response. And there are certain diseases like Behçet's disease, GIA, they work like magic. Intolerance to the conventional immunotherapy. And it has got approval in the 2016 in the US FDA, non-infectious intermediate posterior and pan uveitis. Where are the indicated Behçet's uveitis, to my mind, GIA-associated uveitis, and sometimes HLA-B27 associated uveitis, Bloss syndrome, recalcitrant non-infectious uveitis, and recalcitrant scleritis. How are they used? The infliximab and rituximab is used in the intravenous therapy, and adalimumab and golimumab in subcutaneous therapy. And this is a landmark article, Psychomod trial, which showed adalimumab plus methotrexate for uveitis and juvenile idiopathic arthritis-associated uveitis. We have had a cohort of 15 patients from a tertiary eye care center in India, and we found that the 25 patients which were treated with the adalimumab and by infliximab, and this has been, they are much more effective than with steroids alone. And the golimumab is another agent which has started using it. We have had experience of HLA-B27 associated uveitis in selected cases which are refractory, and with that 14 patients and 71.4% was anterior uveitis. We have used that biologic agents in Bloss syndrome, and the tocilizumab is another agent. The vitreous agent, central macular thickness is decreased in the intermediate posterior and pan uveitis. And this is a 6-year-old girl which has now reached 28 years. She has used all kinds of immunosuppressive agents and biologic agents. Ultimately, used tocilizumab for the gross cystoid macular edema, which is resistant to treatment. And you can see the complete resolution of the macular edema after tocilizumab, intravenous tocilizumab, which is quite effective in uveitic macular edema. Rituximab is another agent, which is a monoclonal antibody against CD20 antibody, and given intravenously in 2 weeks interval. Successful resolution seen in the 83.5% of the uveitis and 93% scleritis, which is quite promising. So screening protocol before starting biologics, which is not forget in our country, particularly Mantoux test and IGRA, and complete blood count, ESR, CRP, hepatitis B surface antigen, ELISA for HIV should be done to rule out infections. So this is a game changer in the uveitis treatment biologic agents. A new one in the block is a JAK inhibitor, which acts on the JAK1 and JAK3. And we have the experience of using one of the JAK inhibitor, tofacitinib, and successful resolution 9 of 10 cases of recalcitrant scleritis in turn to conventional therapy. There is a case of necrotizing scleritis, which after 1 month treatment of tofacitinib has complete resolution of scleritis. In conclusion, ideal treatment of the uveitis, though still evolving, we should remember that the corticosteroids remains the mainstay of uveitis treatment. We are familiar with the usage of immunomodulatory agents, and almost all parts of the country is using immunomodulatory agents with confidence now. Intraocular injection and implants are getting popular. Biologics are a new weapon in our armamentarium, and JAK inhibitors are promising option. Thank you very much. I like to dedicate the talk in memory of my beloved teacher, Professor Dr. Padma Bhushan, Dr. S.S. Badrinath, who have saved me and contribute the life and legacy. I like to, with a humble presentation, contribute the life and legacy of Dr. S.S. Badrinath, who passed away 21st November 2023. Thank you.
I think we will take the questions later. Can we go to the second talk? Can I invite Dr. Amit Khoshla to speak on immunosuppressives when and how much?
Good afternoon. My topic is slightly overlapping with Dr. Biswas. I'll just highlight a few points which I want to add. So immunosuppression, as we know, is all with steroids. We tend to taper too early. We tend to undertreat. But remember, we have 3 drugs: the steroids, the classical immunosuppressive drugs, and the biologics. So what we have learned from oncology and rheumatology is that steroids, we do an induction phase, and then we go into the remission phase, low dose. In biologics also, we go into induction phase and we go to, but the IMTs, the other ones, we start with the lower dose, and then as the tolerance is there, it is basically for maintenance, and then we increase. So we need to remember that the IMTs are not going to be more effective than the steroid. They're just a replacement to the steroids. And every time we start our IMT in India, we always worried about TB, whether it's infection. So what we do is I do all patients with a start, do a CT scan chest, and the patient is strongly Mantoux positive. I even go for a PET scan. I found lymph nodes in the axilla, which would have missed with the CT chest. So why do we need to treat? Majority of time what you see a patient is who's been gone through multiple episodes of uveitis, had 6 weeks of steroids, and then recurrence after a year. But on a long term, they have complications like cataract, glaucoma, maculopathy. So what we have learned over the period is, from the rheumatologists, full remission. Do not believe in a simmering uveitis. Kaplan taught us 6-12 is fine, but I don't agree with that now. We want 6-6 in intermediate uveitis. So this is the article in IGO which we all published during the lockdown. So when do we start? So for me, every patient of intermediate posterior uveitis, I need to start IMT. I look for exception where not to start. But what we are taught generally is, these are the exceptions when you start. But if you think in your mind that I have to start everybody and find exclusions, so who is likely to have a requirement? Those with the initial vision of less than 6/60, who have a retina, choroid, or macular involvement, who have recurrent disease, bilateral sight threatening. All children require IMT. None are going to be resolved with just oral steroids. And in children, if you have cataract, synechia, BSK, hypotony, it means it's a chronic disease. And in those who have intolerance, those patients who do not respond to steroid are unlikely to respond to IMT because IMTs are lesser effective than steroids. There are certain diseases which you know are going to last long. Behçet's, Wegener's, you will start IMT on almost within early days. So classical teaching is in 3-4 weeks, if you are not less to 30 milligram and the disease is active at 3rd or 4th week, think this patient requires IMT. Or when it comes down to 10 milligram, you have a recurrence. So start with it. All posterior uveitis are chronic, and then you will be able to treat it better. There are systemic diseases which require IMT and biologicals. So in these diseases, when you have a systemic disease, you need to follow the rheumatologist. So now what happens is that when you taper the steroids and you start the IMT late, there's a phase where the effect goes away. And you start thinking, oh, is it infection? Is it TB? Is it not effective? So if you do not start the IMT at the right time, there will be a phase at 3 months where the disease will come back. So you have to start within the first one, think that, yes, this is the time for me to start. So how did it all start? So the study has come from 2009, the SIDE trial. So we have these 4 drugs, azathioprine, methotrexate, MMFs, and cyclosporin. Just give me a second. Are they efficacious? No. They only work in 60 to 70% of patients. And that also we are able to reduce the steroids only to 10 milligram. So you have a study which says 10 years, 15 years ago that 30% of your patients are not going to be controlled and will require biologics, or you will start putting implants in them. I'm sorry. So if you have a patient with cataract in a child or has glaucoma, you will start drugs earlier. But conventional immunosuppression is only going to be effective in 50%. So the MUST trial which came out, which compared the steroid implants with the IMT. Unfortunately, we have no prospective randomized trial to say which IMT is superior to the other, except one study which from Madurai which says that MMF is equivalent to methotrexate, but the methotrexate was given orally. So we don't know which drug is. Your experience, you will have to learn which one is better in your setting, which you can do. But this MUST trial initially said, oh no, the steroid implant is better. But at 7 years, they found out, no, it's actually the IMT which is superior, because you don't have fluctuations. You don't have times where you have an active disease. When you give an implant, you tend to not repeat until there's an active disease again. So you tend to miss out the phases when the disease is active. So in the long term, they found at 7 years. But everybody had an apprehension that these drugs cause cancer. So over the last SIDE trial, other retrospective trials have come that the risk of cancer is not higher in patients who use IMT. So this has removed the fear from the ophthalmologist's mind that we use these drugs and we may have to have a risk of cancer. So we have the commonest being methotrexate. Remember, pregnancy is the issue. Sperm, also even males have to use contraception. Nausea is a big irritating. The liver enzymes go up till 3 times acceptable. But remember, it really creates a nausea and depression on the day of the week which you do. And when you go beyond 15 milligrams, the absorption goes down. So you have to use subcutaneous doses. So it is the easiest to monitor, but the patient nausea, you have to stop it in about 1/3 patients. Azathioprine is really effective. I feel it is the best, but monitoring these patients with low CBC, I've also had patients who had bone marrow suppression. We say TPMT test may predict, but no, you can still have suppression even if the patient is TPMT negative. MMF is the costlier one, used more for transplant patient, but yes, it's safer. But both mycophenolate and methotrexate cannot be used in pregnancy. Tacrolimus and cyclosporin are less used, they are less effective, you can use as a combination. Now the question is, I have a patient who doesn't get treated with methotrexate, has active, can I combine another drug? Yes, you can combine methotrexate with MMF, you can combine methotrexate with cyclosporin, but you cannot combine methotrexate and azathioprine. It becomes too toxic. So if the patient can't jump to biologic cost, so you can do combination. So we can use combination of 2 drugs, give steroid drops less than 2, give low dose steroid. You can use combination to treat the patient. So what are the ones available in India? So we have basically infliximab and adalimumab available in India. Infliximab is IV infusion, and adalimumab is the only one which has a prospective randomized trial. So everybody use adalimumab. We have the biosimilar in India. We don't have the original drug, but it works wonders. About 3 companies which make it, all are effective. Now, we are told that macular edema doesn't respond to anti-inflammatory. Yes, but macular edema by itself is not an emergency. You can wait a month or 2 until there are cystic changes or atrophy going in. You can take your own time. You can have. I have a patient of sarcoidosis who was advised Ozurdex. I gave the patient methotrexate. The edema disappeared after 3 months. So CME is never an emergency. So tocilizumab should be used only when it is not improving over a long time. JAK, the small inhibitors, don't work as well. They work at multiple levels. The risk of herpes is there. In adults, the risk of vascular occlusion is there. So I find I've been using ADA for 10 years, ADA to be more effective than tocilizumab. But when the patient cost factor is there, you can use those drugs. Rituximab I use for orbital inflammatory disease and scleritis. It works better. The only problem is that if you give rituximab, you cannot add another drug for the next 3-6 months. It hits the B cell so badly that you cannot use another drug. While in ADA, if you try the ADA first and then go to rituximab, you have a chance to stop the rituximab. So before biologicals, yes, vaccine, especially in IMTs, vaccinate the children and the adults. When to start? Should we first wait 3 to 6 months with conventional IMT, then start with biologicals? But if it's side-threatening, if the child comes with cataract and glaucoma, I would straight away start biologicals. I don't have time for it to prevent the cataract progressing. What does it cause? It causes ANA positivity, it causes skin lesion sarcoidosis, it causes TB, demyelinating disease is a contraindication, and a theoretical risk of cancer. So TNF, higher risk. Yes, can I give TNF to a serpiginous like choroiditis? If you have treated it, yes, I have given patients ADA who have serpiginous choroiditis after they have resolved. How do I monitor? Vision plus the imaging. Sometimes you may have a clinical picture where the disease looks resolved, but we do a FAO ICG, the activity is there. So always before you stop the IMTs, remember you need full remission. Do not stop a patient who is on a smoldering disease which is not clinically active, but is active on imaging. So success is when you have a drug-induced remission, the cells are gone, there is no activity on the imaging, and at least 2 years. If you have taken 2 years to control, keep 2 years at least for it to be tapered. And sometimes for those who have chronic, I have patients on 10 years of biologics. So sometimes they never go into remission. Biologicals do not cause remission. And even in the psychomotor trial, 1/3 of the children came back with uveitis. So once you put a patient on biological, don't tell them you're going to have remission. They just control the disease. Thank you. In STEP, you don't need to go STEP. You can jump one step from steroid to biologicals or IMT. Thank you so much.
Thanks, Dr. Amit. So 1975 is a landmark year in medicine because that gave us the monoclonal body. So in MAB, you know, all of you know, it's popularly called as a MAB. So not only bevacizumab and ranibizumab, there are certain monoclonal antibody which we are using regularly and now become very popular. So adalimumab is one such fully human monoclonal antibody. So our next talk is adalimumab, the early Australian experience with uveitis, and will be delivered by our guest speaker, Professor Peter Macnowski from Sydney University. Over to you, sir.
Great. Thanks very much, Partha. Thanks very much, everyone. So what I want to do is present our real-world experience using adalimumab, Humira, for patients with vision-threatening uveitis. The studies that really convinced everybody that adalimumab was safe and effective were the visual studies, and there were 3 of them, and they I think, clearly showed a significant steroid-sparing effect, increased the time to relapse in patients who did relapse, dramatically decreased the frequency of relapse rates. They were safe, low risk of infectious adverse events. It's very important to exclude infectious uveitis. We need to treat latent TB before starting adalimumab, and it's also important to exclude MS because adalimumab will unmask demyelinating disease. But with that knowledge, people have started using Humira around the world, and in many countries it's now licensed. Sadly, it's not in Australia. But we have had access to Humira for about 4 years, and we've also developed a registry, a real-time outcomes registry, to look at patients with uveitis and how they go. And what I want to do is just show you our early data from looking at the patients that we've treated with adalimumab. I'd like to acknowledge my colleagues who have contributed patients, and Richard Symes, who's really led putting this uveitis registry together. So basically, across Australia, in the last 4 months, we've added 141 patients to our registry and have data on 261 eyes. Basically, we followed them for quite a number of days, for some patients for 5 years plus, the entire time that we've been able to access Humira. And I'll just show you some of the data. So the disease spread is pretty typical for those that we've talked about here. There's obviously a significant number that have idiopathic or undifferentiated uveitis, but as they say, it's the usual suspects: birdshot choroidopathy, which is common in my part of the world, sarcoidosis, multifocal multifocal choroiditis, Behçet's disease, JIA, uveitis, VKH, and inflammatory bowel disease, and some patients with B27-related systemic disease. And I think if you just look at sort of grossly at the data, you can see that there's really a very powerful steroid-sparing effect. If you look at the first dose and the last dose, 66% of patients are off steroids when they had their last visit, and 87% are down to a safe dose. If you sort of drill down more and look at patients where treatment was started within 4 weeks of their uveitis starting, we get this same similar powerful steroid-sparing effect. 65% of the patients are off steroids and 86% are down to a safe dose. There were a relatively small number of patients where we had specific data at 6 and 12 months following the initiation of adalimumab, but it's the same similar effect at 6 months, really quite a large steroid-sparing effect. Half the patients off steroids, 80% of the patients down at a safe dose, and at 12 months that effect is sustained, and similar numbers, 51% off steroids and 87% off steroids. Importantly, it also allowed us to slowly but surely decrease the conventional steroid-sparing drugs. We mostly use methotrexate or mycophenolate as our sort of first-line steroid-sparing drugs, and 75% of the patients were able to stop their methotrexate after 12 months of adalimumab therapy, and nearly 90% of the patients were able to stop their methotrexate. In all the other patients, we've been able to reduce the dose to much lower levels than when they started. It certainly controls the uveitis, and 90% of patients had no anterior chamber cells. 88% of patients had no vitreous cellular infiltrate. And importantly, if you look at vision, the most important thing is that basically adalimumab stabilizes your vision. A small number of patients get significant improvements in vision, but the vast majority of patients, their vision just stabilizes, and only very small numbers of patients lose vision. And I think that's a really important take-home message from this, that the vision that you have when you start adalimumab is usually what you finish with. So the sooner and the earlier we're able to access a drug like this, the better visual outcomes our patients are going to get. As one would expect and predict, it gets rid of macular edema in many patients, and probably, although we don't have the data yet, decreases the number of relapses. So basically, what I've shown you in this very brief overview of our data is that basically our data supports the earlier visual studies. It dramatically decreases the number of patients who lose vision. It stabilizes or improves vision in the vast majority of patients. It has a very powerful prolonged steroid-sparing effect and enables the majority of our patients to stop prednisolone therapy, or at least get down to the current safe dose of 7.5 milligrams a day or less. And importantly, it allows us to decrease the treatment load, which greatly improves patients' quality of life. So I remember going to an American Academy meeting about at least 15 years ago, I can't remember exactly when Stephen Foster said that basically for uveitis patients, the mission is remission and the goal is durable steroid-free remission. And now I think we finally have a drug that will allow us to do that with most of our patients. Our registries have been going for a long time at the Institute. The uveitis registry we only bought online about the time of the IOIS meeting in Berlin last year, and this is our really earliest data. We've concentrated on just getting as much Humira data as we possibly can. But if any of you are interested in joining the registries, broadly they're across nearly 17 countries, quite a few countries in Europe, Australia, New Zealand, the UK are starting to use this outcomes registry. You do it online in real time, and after the first visit, it takes about 3 minutes to do a patient visit. So that's basically all I wanted to say. I'd like to take this opportunity to thank the organising committee for inviting me to speak here. I sort of invited myself because I came here as part of a RANSCO College delegation to talk to the AIOS, and I twisted a few arms to be able to give some talks. So thanks very much. It's wonderful to be here face to face after all those years of Zoom meetings, and thank you very much, and thanks for being here. Thank you.
Thanks, Professor Maknowski. So you have treated the patient with steroid, immunosuppressives, and biologics. So inflammation has resolved, but the patient has developed cataract. So now let's see. So next talk is on optimizing outcomes of cataract surgery in uveitis, and that will be delivered by Dr. Bedanayagi from Arvind Eye Hospital.
Good afternoon, everyone. I thank AOS and the scientific committee for giving me this opportunity. So we are here to discuss how to optimize the outcome of cataract surgery in uveitis. So we all know uveitic cataract is one of the common complications of uveitis. So they may be because of uncontrolled, unsustained inflammation, or because of the treatment as such, like use of high dose and long duration of steroids in these patients. So the moment a surgeon looks at a uveitic cataract, the first thing that comes to his mind is a surgically demanding procedure. But for a uveitic person, the first thing that comes to his mind is how am I going to control the inflammation preoperatively and postoperatively. So unless due diligence is given to control of inflammation in perioperative period, even in a surgically good hand, these patients are going to have a disastrous postoperative period. So the outcome of the surgery is going to depend on the case selection, pre-op evaluation, pre-op management, intra-op management, and post-op complication. So as we said earlier, the first point is case selection. So we have two categories of patients. So one is visually significant cataract with well-controlled inflammation. In these patients, you can actually expect a good visual outcome, but you have another category. These are patients who have cataract impairing posterior segment. So these patients may have a posterior segment pathology. Here we are operating mainly to see what's happening in the posterior segment. So it's more of a therapeutic surgery than for a visual outcome. And again, we have few factors that has to be considered to optimize our outcome. One is the type of uveitis, that is uveitic diagnosis, and the response of the patient to the standard therapy so far. So what was the clinical course? Then you have 3 months of quiescence. So that is a standard rule which you don't want to break at any point, because you will suffer at maybe post-operatively when the inflammation is very bad. And always look for concomitant ocular pathology like optic nerve involvement and macular involvement. So as we said earlier, management is different in different type of uveitis. For example, we have Fuchs uveitis. These are patients who have good post-operative outcome. So you need not even wait for 3 months. So usually we say Fuchs and lepto, you need not wait for 3 months of quiescence. You usually get a very good post-operative outcome. The most common complication is vitreous opacification, and if it is progressive, you can go ahead and do cataracts, do pars plana vitrectomy in this patient. But on the other arm, you have juvenile idiopathic arthritis. These are children who present to us late because of white eye uveitis. So when they present to us, usually they have complications like cataract or band-shaped keratopathy. But you have to have a balance as to wait for a zero control of inflammation and cataract surgery, because these children are in their amblyogenic age. And even worse down the spectrum, you have Behçet's disease. Even after 6 months of quiescence, these patients may have poor visual outcome because they have concomitant co-pathologies like optic nerve involvement. And other diseases like VKH and SO, if you have periocular control of perioperative control of inflammation, usually their visual prognosis is very good. So coming to investigation, apart from your routine investigations like A scan, these patients may need additional investigation. For example, UBM to look at the ciliary body and zonules and posterior capsule. For example, if a patient had an intravitreal injection in the past and maybe a lens stitch. So in these cases, you would like to do a UBM to see the posterior capsular status before taking him for a surgery. And again, ultrasound will help to look at the posterior segment if the cataract is very dense, and OCT will help to look at the macular thickness, edema, and epiretinal membrane before posting these patients for surgery. This is the main part, preoperative medication. The first and foremost is steroids. So the dosage of the steroid in the pre and post-operative period will depend mainly on the type of uveitis and the course of the patient with the disease so far. And again, you can go for intraoperative steroids also. It can be subconjunctival, intracameral, or intravitreal, but this will depend on the tissue handling and the anatomical location of the disease to begin with. Then if the patient is a patient with non-infectious uveitis and on immunosuppressive, you can continue your immunosuppressive. But if it is an infectious uveitis patient and you have treated it, for example, it's a case of herpes zoster ophthalmicus, you have to restart your antiviral treatment 3 weeks before surgery. So coming to intraoperative management, it's mainly the pupillary management which is different from rest of your cataract surgery. If you see, most of our patients have posterior synechiae and a small pupil. So this is a small video which will tell you how to manage a patient with small pupil. So you can introduce a cyclospatula through a side port made in a quadrant opposite to the posterior synechiae and sweep it across to break the synechiae between the iris and the anterior lens capsule. This pupil can be further stretched manually using 2 Hoagland's hooks. You can push the iris in the horizontal and vertical meridian 180-degree apart to stretch the pupil. But like in this patient, if the pupil is thin and atrophic, if you try to do a manual stretching, it may cause ripping of the iris. So in those cases, you have to go for self-retaining iris hooks. So usually we use self-retaining iris hooks through subparacentesis side ports, and we use 4 iris hooks. If needed, you can add one more iris hook just below the incision of your routine corneal incision, and you can see a diamond pattern of the dilatation. Next, recently we have pupil expanders. Actually, these are silicon material, and because of the material, it causes less inflammation and irritation to the iris. And again, this stretches the pupil in a circular manner and causes less stress to the iris. This can actually be introduced through a routine 2.2 corneal incision. Next, you have capsular management. You have to go for a larger rhexis, a minimum of 5 millimeter rhexis, because these patients are more prone for capsular phimosis in the longer run. The rest of the surgery can actually be continued as you do in any of the routine cataract surgery. Then you have IOL types. Hydrophobic acrylic IOLs are found to be biocompatible in these patients because they cause less of post-op inflammation and posterior capsular opacification. So always the rule is place the IOL in the bag. Even if it is a 3-piece IOL, don't place it in sulcus because it can further worsen the inflammation by irritating the iris continuously. So placing in the bag IOL is the thumb rule in uveitic cataracts. Post-op complications, it may be either early complication or a late complication. Early complication, the first one is excessive post-operative inflammation. So this may be either because of your tissue handling during the surgery or because of the disease as such. These may cause posterior synechiae and IOL capture. The other common complication is cystoid macular edema. This can be treated with difluprednate with NSAIDs. If it is still persisting, then you can go for periocular steroids in this patient. Again, always look for raised IOP or hypotony in these patients because of excessive inflammation. Late complication, these patients are again prone for posterior capsular opacification, but do not attempt NDR capsulotomy because the chance of retinal tear is very high, and wait for 6 months before you are planning a NDR cap. Capsular phimosis, as we said earlier, if you have done a large rhexis, usually there won't be cocooning of the capsule. But if the patient had developed one, then you can give relaxing radial incisions to reduce the cocooning. So the take-home message here is period of documented quiescence. No, sometimes even the patient will say, inflammation is right now under control, I would like to go for a surgery. But then at the end of the surgery, it will be you who will be in the suffering phase. So always wait for 3 months, except for Fuchs or in a leptocataract. Optimization of immunosuppression in the perioperative period. Avoid topical anesthesia because there may be a surgical surprise on the table. So avoid topical anesthesia. In the back, monofocal IOL is the thumb rule. Expect the unexpected, and surgery is not the end here. Always look for post-op complication and act proactively so that we can optimize the outcome in these patients. Thank you.
Thanks, Bedanayaki. So the oral steroid, immunosuppressives, biologics, and cataract surgery. So these are the topic open for discussion. Any audience question?
I have one question regarding cataract surgery, particularly in JIA patients. now we are having biologics. So should we go ahead with cataract surgery with PCIOL implantation under that immunosuppressive therapy, or should we go ahead with lensectomy and pars plana vitrectomy?
So we have had a good experience even with IOL. It depends, as we said earlier, how the child had responded to the treatment during the course. So if you know the child is usually gets recurrences in between, even after 3 months of quiescence, you see how the child had responded so far. So you can always go for and again the age matters. Usually less than 2 we go for leaving the child aphakic. If it is more than 2, it's if the inflammation is well under control, you can actually place the IOL.
Yeah, the only other thing I'd add, I agree completely, is that since we've been using adalimumab, particularly in the children with JIA, the amount of cataract surgery and glaucoma surgery that we've had to do has gone down, because I think we control the uveitis better, so you get less glaucoma, you don't get cataract as often as you used to. I mean, obviously, if they present with cataract, they've got it, but overall, over the last 6 years, the amount of cataract surgery in our children has gone down, because I think we finally can control the disease using the Sycamore study principles.
So in the case of cataract, a quiescent eye post-uveitis, 3 months quiescent, what is your protocol for perioperative steroids before cataract surgery, as a rule?
It depends on the... It depends on the type of uveitis. If it is just HLA-B27 anterior uveitis, not much of tissue handling during the surgery, you can leave the patient alone. Like, you need not usually give a perioperative steroid. But if you know that patient develops an inflammation, if it is a VKH, and if you know that the patient already had intermediate inflammation in the past recently, then you can go ahead and give, sometimes like we give even PST, posterior subtenon injection, before taking up the patient for surgery to prevent worsening of the inflammation post-operatively.
Can I?
Yes.
I think two clinical findings are very important while deciding the surgery, especially in adult patient. One is that the posterior synechia. How extensive is the synechia? Because there will be a lot of reaction after that. And the second thing is that macular edema. I think these two factors actually decides the course of the cataract surgery in uveitis patients. If there is a history of macular edema, I think it's always better to combine the perioperative, like Ozurdex. You have to combine the Ozurdex with the cataract surgery. And if there is a significant posterior synechia, as obvious that it will cause a lot of inflammatory reaction after RA, so you have to take proper precaution. So now coming to our first topic, the oral corticosteroid, I have a question to Professor Maklonsky and Dr. Biswas, that what are your recommendation of oral steroid and immunosuppressives in a patients with anterior uveitis?
I think I'm audible. I don't really use oral steroids in anterior uveitis. I give frequent topical steroids. I give even 15 minutes interval steroids, topical steroids in fibrinous anterior uveitis. But in cases where there is a lot of fibrin is there, I give a short burst of oral steroid. 40 milligram per day, short burst for 3 or 4 days, and get rid of the fibrin and inflammatory reaction, and then go over to topical steroids. I don't know whether others use it, but over the years I found it quite gratifying.
Professor?
Yeah, I agree. I mean, it's uncommon to need oral steroids. I think really someone with severe pain that you just can't control, a lot of fibrin, sometimes with a hypopion. These, fortunately, are usually young, otherwise well patients, so they'll tolerate oral steroids reasonably well. But I think more commonly, rather than oral steroids, it's those patients with frequent recurrences that we'll just put on methotrexate to give them good disease control.
So the notion is that you have to use the oral steroid where the anterior uveitis is not responding to the topical steroid, when it is recurrent, and sometimes like severe fibrinous reaction, those times.
Yeah, I just want to add, maybe because we are in India, we know newer biologicals have come up. They have done a wonderful job in non-infectious uveitis. But I would like to quote an example from our department. It was a child with pediatric VKH. We started the child on methotrexate. The child was not responding. We shifted to MMF, still not responding. Then we went to newer biological. The child gained back 6/6 vision. So we were all happy. But within 6 months, he came back with choroidal granuloma, multiple choroidal granuloma, not systemically symptomatic. So you can't just stick to your diagnosis always. When you have taken the step to give a newer biological, then you should follow up the patient and always keep at the back of the mind that our country, it's prone for infectious uveitis and systemic infection. So in that child, when we did a CT scan, he had an active pulmonary TB. So we have to start him on ATT. So yes, they do wonders, but we have to keep in mind that we have to have a proper follow-up for these patients.
May I ask a question, please? Is there any role of IV methylprednisolone in a patient who is having disc edema with CME? Like, do you routinely use? Because in one case we used it because the patient was asked to get an DEXA implant. So surprisingly, the edema, the cystoid macular edema disappeared and the blurred disc margins also were regularized. So her vision from 6/24, it turned to 6/9. So is there any role as such?
I think that is an anatomical diagnosis. You should always try to find an etiology. Maybe it would have worked at that point, but we should know why it came in the first place.
It was diagnosed as a uveitic case only
No,
because she
uveitis-
underwent a vitrectomy for the haze post-cataract surgery.
No, you are saying inflammation was
Yes,
post-cataract surgery.
Yes.
It, other than that, the patient was absolutely fine, or it was a uveitic cataract to begin with?
No, it wasn't a uveitic cataract, ma'am.
So
for vitreous haze, they did vitrectomy initially, and
Okay.
then later she developed macular
In case of disc edema,
Yes, sir.
it would be prudent to give intravenous methylprednisolone. You need to, because it acts so fast, and you don't have residual complications of the disc edema to go to the optic atrophy and all. So you can control the inflammation very rapidly and very efficiently. In case of VKH, we use that in active stage, intravenous methylprednisolone all the time.
Thank you, sir.
I think there are two components in your patient. One was the optic disc involvement and second was the macular edema.
Yes.
So if you take one by one, like macular edema, yes, we should not recommend that treating a macular edema with pulse corticosteroid.
Yeah.
But here it is associated with your optic disc involvement. So I think it's the ideal choice. When you use pulse corticosteroid, definitely it will reduce the macular edema also. So I think just for the audience, there are primarily three conditions where pulse corticosteroid can be used. The number one is optic disc involvement. Number two will be the macular threatening serpiginous choroiditis where you have ruled out. And the number three will be the exudative retinal detachment, because normally whatever the treatment we have, if you see that desired time to start action, like all immunosuppressive, they take months to start the have the desired mode of action. Whereas in detached retina, the IVMP, it reaches as fast as 6 hours. So that's why I think it's a preferred mode of treatment in such conditions. Yeah, it can be.
Thank you so much.
Maybe we can conclude the session. Sir, thank you. And I thank All India Ophthalmic Society and the Scientific Committee for giving this opportunity to bring out all the uvea giving out a uvea subspecialty day. And I thank the audience for staying back even very close to the lunch. Thank you.
Thank you. Very good.
Fabulous to see you. Congratulations.